Okay, sir. So we are live,
Yes.
and with all your concern, I'm starting the session. So good afternoon and a warm welcome to all the dignitaries present here. Myself, Rupsha from ClearNet, assigned as a session assistant to ensure a seamless experience. ClearNet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that ClearNet is the digital partner of this event organized by National Neonatology Forum, Gujarat. And the topic of today's session is optimizing antimicrobial use to prevent antimicrobial resistance in newborns. So let's begin today's session, for which I would like to hand over this session to Dr. Kunal sir. Over to you, sir. Please proceed with your talk.
Yeah. Thank you so much, Rupsa. So, as we are continuing with our series on every Wednesday, so today we have selected an important topic that is a concern for everyone is the antimicrobial resistance. And today we have an expert, Dr. Sindhu, with us. Thank you so much, ma'am, for joining with us. As a moderator, we have Dr. Vishal Goyal with us. Thank you, Vishal, for accepting the invitation. And today we are doing this in collaboration with AOP Gujarat as well as AOP Vadodara. We have Dr. Tushar Shah with us, who is he is the president of AOP Gujarat. Welcome, sir. And we have Dr. Snehal with us, who is the president of AOP Vadodara. Welcome, ma'am. So first, I would request Dr. Tushar sir to say a few words.
Thank you, Dr. Kunal. And it's a pleasure to associate with NNF always and with Dr. Shwetal Bhatt as president, who is a very dear friend, along with you all who are also a part of AOP Gujarat. It's a privilege that AOP Gujarat and AOP Vadodara are co-hosting this event with NNF Gujarat. And as we celebrate the newborn week of 2024, we know that we have done various activities also with NNF, like neonatal protocols under the action plan, and also KMC week celebration at Patan. So all successful events, and all thanks to your NNF team, including Dr. Shwetal and Dr. Kunal. At this point, as we go ahead with this very interesting session on optimizing antimicrobial use to prevent antimicrobial resistance in newborns, I also thank the faculty for today, Dr. Sindhu Sivanandan, and also the moderator, Dr. Vishal, to take this session today. And at the same time, I also welcome on behalf of AOP Gujarat all the participants who are joining today. At this point, just a last small request which I would like to make before I stop my talk is that I request all people who are listening to this session live to join for the annual Gujarat Pediatric Conference, that is Guj Pedicon at Abu Road, where also in the workshop on the Friday we have a full session on neonatology protocols by Dr. Ashish Mehta and his team. So I request all to join in big number for the whole conference, including the workshop, where we have a neonatology protocols workshop, which is being conducted by Dr. Ashish Mehta. So with that, I congratulate all of you and thank you very much for having us to join with you. Thank you.
Thank you so much, Tushar sir, for your enlightening words. With us, we have Dr. Somsekhar sir also. Welcome, sir. Now I request Dr. Shwetal ma'am to say a few words.
Thank you so much, Dr. Kunal. And thank you, Tushar Bhai, for collaborating with us. At the outset, I would like to thank Dr. Sindhu ma'am. She is an excellent orator, excellent medical mentor. I have heard several times her teaching skills are really commendable. And this is the best opportunity for Gujarat NNF as well as AOPG and Academy of Pediatrics Vadodara to have her on this academic platform. Thank you, ma'am, for accepting our invitation. I would not like to waste much time. So I request Dr. Vishal to introduce our expert faculty and go ahead with the expert talk.
Thank you, ma'am. So, as we know, today's topic is optimization of the antimicrobial use in the newborn to prevention of the antimicrobial resistant. For that, today we have a Dr. Sindhu Sivanandan madam from the Chennai. She is a MD pediatric with the DM neonatology, and she did the fellowship in neonatal and perinatal medicine at Canada. Currently, she is working as a senior consultant at Department of Neonatology Curie Hospital, Chennai. She is interested in the quality improvement in the healthcare as well as systemic review. She has a multiple national as well as international article, more than 40 in number. She is a member of NNF Clinical Practice Guidelines Working Group and Editorial Board. And she is a part of the WHO Guideline Developmental Group for the care of the preterm or low birth weight infant released in 2023. She is section editor for NNF Clinical Protocol in Perinatology and Neonatology Guideline for the pediatrician. So welcome, ma'am, and over to you, ma'am.
Thank you so much. At the outset, I want to thank NNF Gujarat, AOP Gujarat, and AOP Vadodara, as well as Shwetal ma'am for inviting me to participate in this webinar as a part of Newborn Week celebration. And the theme is optimizing antimicrobial use to prevent antimicrobial resistance in newborns. So in today's talk, I shall be covering how we can diagnose sepsis optimally, whereby we can do optimal antimicrobial stewardship. So understand that we need to understand how neonatal sepsis differs in low, middle income and high income countries. First, our burden is very high. It is 6 times as high in high income countries. So in HICs, the incidence is 1 to 5 per 1,000 live births. But when we look at Asia, the incidence is 16 per 1,000 live births, which is 5 times higher. Secondly, early onset sepsis contributes to 2/3 of all burden of neonatal sepsis. So this indicates that either the transmission of infection is from the intrapartum maternal risk factors, or there is a very ultra early onset from the caregivers with an horizontal transmission also playing a part in early onset neonatal sepsis. Gram-negative sepsis contributes to 2/3 of all neonatal cases. We know that gram-negative sepsis results in higher mortality and higher morbidity. So 2/3 of all cases. So not only are we facing a very high burden, but also we are tackling with organisms which are associated with high mortality. Thirdly, Dennis data provided that the distribution of microorganisms is not much different between early and late onset sepsis. Even in early onset cases, we continue to have organisms such as Klebsiella, E. coli, Acinetobacter, and Staphylococcus aureus, and the pathogen profile is pretty much similar across early and late onset sepsis cases. The most important one is that the antimicrobial resistance is very high. 80% of our bacteria are uniformly resistant to the WHO recommended first-line antibiotics, which is penicillin and an aminoglycoside combination. So which necessitates that we frequently upgrade antibiotics and we face a very high AMR challenge, antimicrobial resistance challenge. The rates of multi-drug resistant organism is also very high. The data from New Delhi, I shall also be telling about the Pune data, shows that 80% of Acinetobacter, half of all Klebsiella, 40% of E. coli are resistant to 2 or more antimicrobial drugs. 1/3 of all Staphylococcus aureus are methicillin resistant. So which leaves us with a handful of antimicrobials to tackle neonatal sepsis. This data from Pune also mirrored what is being seen in New Delhi. In this study from KM Hospital, which looked at 93 culture-positive infections in 83 neonates and included 11 cases of meningitis, there was an 18% mortality, 85% of bugs were sepsis was caused by gram-negative bacteria, and a very high drug resistance to aminoglycosides, third-generation cephalosporin, as well as carbapenem. Interestingly, 30% of cases of Klebsiella were resistant to colistin And they recommended that even in the first antimicrobial sensitivity profile, colistin be included in the antimicrobial susceptibility testing results. So how do we tackle it now? So I would like to answer this by answering these questions. First is we should know how to reliably diagnose neonatal sepsis. Second, blood culture is often reported as sterile. Why is it so? How can we take blood culture in optimal information to guide us on antimicrobial use? What is the role of sepsis screen? When do we do it? How do we trust it? And how we can use antimicrobials judiciously. So how can we diagnose sepsis reliably? Often we rely on signs and symptoms, but we know that the signs and symptoms of neonatal sepsis overlap with signs of other diagnoses. It can be general symptoms like fever, irritability, not feeding. We can have gastrointestinal symptoms, respiratory symptoms. These would overlap with gastroenteritis, respiratory distress syndrome in preterm neonate, and or any other cardiovascular illness or central nervous system manifestations. So sepsis signs are very, very non-specific. So what do we do when we assess a baby in the early days? How do we diagnose sepsis? So we take in a combination of neonatal risk factors, maternal risk factors, and put in the symptoms to diagnose sepsis. Neonatal risk factors which place these babies at higher risk of sepsis include prematurity, low birth weight, multiple pregnancies. Maternal risk factors include maternal urinary tract infection in the last 2 weeks before delivery, chorioamnionitis diagnosed with maternal fever, uterine tenderness, maternal tachycardia, fetal tachycardia, foul smelling liquor, maternal colonization with GBS, although we are not universally doing screening in the 35 weeks or beyond cases, duration of rupture of membrane, when there is a complicated delivery, fetal tachycardia, fetal distress, or alterations in heart rate variability. Also, we could get a clue from the age of onset of infection and whether we are dealing with the sepsis in the community or in hospital. So we factor in neonatal risk factors, intrapartum maternal risk factors, as well as the symptoms. There are some sepsis calculators which are used in high-income countries which take in a combination of these to derive what will be the risk of sepsis. If there is significant risk, then the baby would be started on antibiotics after taking appropriate culture. However, if the risk of sepsis is low, these babies can nearly be observed for the first 72 hours while awaiting culture results and observing for clinical signs. So in such cases, antimicrobial use would be significantly reduced. Irrational empirical antimicrobial therapy is associated with higher incidence of late onset sepsis, neonatal mortality, necrotizing enterocolitis, higher colonization rate with fungal infection, as well as increased prevalence of antimicrobial resistance. Therefore, decreasing antimicrobial use is very important, and in high-income countries, they have shown that the use of these sepsis calculators have reduced the antimicrobial use. This is an example of a calculator which is used for early onset sepsis assessment. This is from Kaiser Permanente setup. Here, we factor in what is the baseline incidence of early onset sepsis in that particular unit or city. So here, the maximum incidence is only 4 per 1,000 live births. Gestational age, the minimum gestational age that is for this calculators are useful is 34 weeks only, not below 34 weeks. We put in the highest maternal temperature, which is a surrogate marker for maternal infection or chorioamnionitis. put in the duration of rupture of membrane, GBS status were available, and the intrapartum antibiotics. Was the mother initiated on any antimicrobials, and before delivery, how many hours she was covered with antimicrobial. So when we put in these the information, we get the risk of early onset sepsis for that particular baby. Then we factor in whether the baby is asymptomatic, equivocal, or has sepsis. So for well-appearing baby, from the baseline risk, the sepsis risk decreases. Whereas if the baby has clinical signs of sepsis, from the baseline risk, it is high. So now the calculator also gives us recommendation whether we can just wait and observe the baby, or whether we should start empirical antimicrobials. So the clinical signs and symptoms as used in this particular calculator. So well appearing, what is equivocal illness, what is clinical illness, they have clearly labeled. When we say clinical sepsis, infection illness, the baby needs respiratory support, has hemodynamic instability, has encephalopathy.
Rupsa, can you mute everyone else?
Yes, I'm muting her.
Needs a supplemental oxygen, or has low Apgar scores. Equivocal are only just tachycardia, tachypnea, or temperature instability, but they don't last for more than 2 or 4 hours. So from the baseline risk, so this is from that calculator, the baseline risk is derived from the maternal intrapartum risk factors. So that baseline risk 1.10 is plotted here. For a well-appearing baby, the risk of sepsis is very low, whereas for a high-appearing sick baby, the risk of sepsis is really high. So in this baby, sick baby, we would be starting antibiotics. For well baby, we would be avoiding antibiotics. So as I said, the use of these early onset sepsis calculators has resulted in tremendous decrease in the antimicrobial use. This is in the Western setup. Now the question is, oh, this is interesting. Can't we use such a calculator in our setup? What is the problem with extrapolating the same calculator? So if you had heard it, I had said that the maximum incidence of sepsis which was used there was only 4 per 1,000. However, in our Indian scenario, our rates of culture positive sepsis is high, 30 per 1,000. So we are at a very, very high risk factor scenario, and these calculators may not be really useful. These calculators are not applicable when the baby is less than 34 weeks of gestation. Prematurity is an important risk factor for neonatal sepsis. GBS, use of GBS screening and intrapartum antibiotic cover for GBS is universal in high-income countries. However, we do not screen for GBS, nor routinely antibiotic prophylaxis is used intrapartum. So hence, the National Neonatology Forum in their recommendation advised against using these early onset sepsis calculator. An example is the one used by the Kaiser Permanente for the management of well-appearing or asymptomatic neonates born at or after 34 weeks of gestation, even though they have maternal risk factors for early onset sepsis. So we cannot extrapolate or use these calculators in our setup. So then the question is, how do we start antibiotics? Whom do we diagnose and label as sepsis? What is the indication for starting antibiotics? So we have recommendations from the Indian Council of Medical Research as well as the NNF, which tell us, give us guidelines. What they say is every neonate born in or brought to a health facility, when you suspect symptoms, assess them clinically. Look for yellow and red flag signs. Red flag signs are those which mandate immediate initiation of antibiotics after we send blood culture or evaluate the baby for meningitis as accordingly. What are these red flag signs? These include shock, presence of sclerema, respiratory distress requiring mechanical ventilation, or when the Silverman score is more than 6, bleeding from multiple sites, which indicates disseminated intravascular coagulation, distress in a neonate with onset more than 6 hours of life, or if the baby is less than and the mother has clinical features of chorioamnionitis. Then these are red flag signs which tell us that we should initiate antibiotics. Baby is at higher risk for neonatal sepsis. However, when you have yellow flag signs are equivocal signs which may or may not point to bacterial infection. These include presence of sepsis, poor feeding, tachycardia more than 1 hour, respiratory distress with Silverman score less than 6, hypotonia, lethargy, feed intolerance, fresh onset apneic episode, fever or hypothermia. So these are yellow flag signs. Then there are maternal risk factors, which include unclean vaginal examination, prolonged rupture of membranes more than 18 hours, preterm premature rupture of membranes, maternal urinary tract infection, diarrhea, or maternal fever. All these within the 2 weeks prior to delivery. So when we have any red flag sign, there is a high probability of sepsis. Start antibiotics after taking blood culture. When we have 2 yellow flag signs, then also there is a high probability of sepsis. When we have 1 yellow flag sign, but the baby is more than 32 weeks, please wait and watch. Observe the baby's vital signs. Observe for the next 48-72 hours. Watch for emergence of red flag sign and new yellow flag sign. But if the baby is preterm, less than 32 weeks, and even if you have 1 yellow flag sign or maternal risk factor, take blood culture, start empirical antibiotics. So 1 red flag, high probability of sepsis, 2 yellow flag sign, high probability, only 1 yellow flag sign, but baby is above 32 weeks, wait and watch. So these are the same that is being recommended by NNF India. Although some of these recommendations are weak, they are not graded. They are basically from expert consensus. However, they have laid out definitive de-escalation criteria, which means that even if you have started antibiotics for 2 yellow flag sign or because of prematurity with 1 yellow flag sign, they say that review at the end of 48 hours. If the baby's signs have disappeared and the CRP is less than 12, stop antibiotics. Wait for the blood culture results and continue observation. However, if the baby continues to have signs or is showing signs and showing improvement, continue antibiotics. Look at your blood culture, tailor your antibiotics based on blood culture and CSF report. However, if there is worsening, repeat your blood culture and consider escalation of antibiotics. Always be guided by your blood culture antimicrobial sensitivity reports. So there are definitive de-escalation criteria being laid out when we start empirical antibiotics. This is another study called as the Bernard study, which looked at the burden of antimicrobial resistance in neonates from health facilities from developing countries. The developing countries included India, Bangladesh, as well as Pakistan, in addition to the African countries. They noted that when we have no sepsis, the risk for death is less. However, when we have clinical sepsis, the incidence in the low-income countries being 166 per 1,000 live births, there was a higher risk of death. The mortality risk was significantly higher. The mortality was higher when the blood culture was positive. And look at the incidence of culture positive sepsis in these low middle income countries. It was 46 per 1,000 live births. And majority of the deaths occurred in the early period. These vertical lines correspond to 3rd day, 7th day, and 28 days. So there is a higher risk of early onset death, especially with the culture positive sepsis. Now we have some data from the health facilities. What about in the community? When we assess neonates with respiratory or other symptoms, how do we decide? In 10% of the cases, there is possible serious bacterial infection when they present with symptoms in the community. 75% of the cases may be normal. Another 10% show mild illness. So the WHO Young Infant Study has laid down 7 clinical signs. If you have one sign or symptom, the sensitivity for diagnosing possible serious bacterial infection, which mandates antibiotic initiation and referral if necessary. The sensitivity was 85% and specificity was 75%. This holds true for babies between 1 to 59 days. These babies, 1 to 59-day babies, are called as young infants. What are the 7 clinical signs or symptoms? Difficulty feeding, history of convulsions, very lethargic that the baby is moving only when stimulated, tachypnea or chest retraction, hypo or hyperthermia. When you have any one clinical sign or symptom, suspect possible serious bacterial infection. So the term is PSBI and it covers both sepsis, meningitis as well as pneumonia in these young infants. However, because it is only a clinical diagnosis, it may overlap with some viral infections, gastroenteritis, urinary infection, skin infections, and other diagnoses like respiratory congenital. However, this is what we can do in the community where we do not have more sophisticated investigations like the chest X-ray or the blood culture being available. Neonatal sepsis is associated with very high mortality. So timely identification and management for these neonates becomes critical. Hence the recommendation to diagnose PSBI in this manner. So the first dose antibiotics and hospital admission is recommended for PSBI, especially when they have critical illness. The penicillin and aminoglycoside combination is the first line management in the community. The ANISA study is one large study which looked at the causes of infection in young infants who present with signs and symptoms of possible bacterial infection. They showed that only 18% were attributed to any infectious etiology and half of these were due to viral infection. Now the question is, would you still recommend diagnosing sepsis based on these 7 clinical signs, where 50% you say are due to viral infections because of the excuse me, severity of neonatal sepsis and the higher risk for mortality? Yes, but after initiation and appropriate hospital referral, reassess your diagnosis, and if not needed, these antibiotics can be stopped. And they may be life-saving in neonates where referral may not be possible or where parents may not accept hospitalization. These babies can be treated with oral antibiotics in the community. Coming back to the facility setup, let's review why blood culture often is coming back as negative or sterile. Then how does it guide us? How can we improve the rates of blood culture? So what are the factors which affect the blood culture results? One, timing of culture is very important. Antibiotics before administering antibiotics, if we take our cultures, then the likelihood of getting a positive result is very, very high. The technique, the thin preparation and use of appropriate disinfectants is very important. The culture and the blood ratio, it should be 1:10. The volume of blood that is taken, it should be at least 1 ml. So if we pay attention to all these, then getting a culture positive result is very high. So in neonates, as far as they are concerned, 2/3 of septic infants have low level of bacteremia, which is defined as less than 10 colony forming unit per ml. and half of them may have even less than 1 colony forming unit per ml. So when the colony in low colony count bacteremia, if we take a low volume of sample, then it is likely to be reported as negative. Therefore, it is mandatory. Keep in mind that infants, neonates have low-level bacterial sepsis. Take at least 1 ml of blood for blood culture. The blood to media ratio, it should be 1:10. Having the adequate appropriate volume will decrease bacterial contaminants and also encourages the true bacterial growth. Decrease the contaminants. Contaminant rates in blood culture should be less than 3%. Use appropriate chlorhexidine or isopropyl alcohol for skin disinfection before we take blood culture. Do not take them from peripheral venous catheters. Timing of culture before antibiotics being administered. Now, how long does it take in the usual scenario for culture to be reported? In high-income countries, it is very quick, 48, 72 hours. The culture reports as well as antimicrobial sensitivity results are available. However, it can be delayed more than 72 hours or up to 5 days for a culture to be reported. Why is there so much delay? So what can we do to improve? So this is the traditional method where we take it in the blood culture bottle, subculture it to culture plate media, await bacterial growth, then characterize. However, when we use automated techniques like the BACTEC, the culture reports are really quick. So one method to use or expedite the culture results is the MALDI-TOF, which stands for Matrix Assisted Laser Desorption Ionization Time of Flight Spectrometry. What we do, we sample, put it in the automated culture media. They look at the carbon dioxide levels detected by the produced by the microbial growth. Once a certain level is detected, the bottles are flagged. Then we can take a centrifuged sample from the culture bottle directly, prepare a bacterial pellet. Once that pellet is taken, we can do gram staining, which takes less than 1 hour. We can do the MALDI-TOF test, which can directly detect what is the type of bacteria which is growing. Subsequently, using methods such as the VITEC, we can do antimicrobial sensitivity testing. And if we do the PCR, point of care PCR, we can detect the antimicrobial sensitivity as well as the bacteria very quickly. So in the pre-MALDI-TOF era, we look at whether the colonies are gram positive, gram negative, how they are arranged, and then look after overnight incubation. But now we can do the bacterial fingerprints. The peptide mass fingerprint is available, which tell us which bacteria is growing in the culture bottle. Traditional antimicrobial sensitivity reports take time, but when we do automated methods, we can get the the antimicrobial sensitivity results are also very quickly determined, and we can determine the minimal inhibitory concentrations of the antibiotic based on these parameters. So this is a blood culture report from a baby. So it tells us what is the time to positivity. True cultures are generally positive within 24 to 48 hours. Delayed bacterial growth can be an indicator of contaminant. So the time to positivity also is available. The organism grown in culture. So see, by 60 hours, we get to know the bacteria which is causing sepsis. The VITEC provides the antimicrobial sensitivity. Here it also provides the minimal inhibitory drug concentration, which we can interpret as intermediate or sensitive. So when we look at the MIC guiding table, among the sensitive antibiotic, for example, in this case, you have 4 antibiotics which are sensitive: 4-trimoxazole, cefoperazone sulbactam, minocycline, and meropenem. So we look at how far The MIC is from the sensitivity MIC breakpoint. So the farther it is, the higher is the antimicrobial therapeutic index. So in this case, compared to cephalosporin, sulbactam and meropenem is a better antimicrobial choice because of the higher therapeutic index. So not only you can decide what antibiotic to use, among sensitive antimicrobials, we can help us to decide which might be a better option at the outset. So there are some quality indicators for blood culture that we can use in the unit. Proportion of blood culture which show a positive pathogen, which is called as the culture positive rate. In high income countries, the range is between 5 to 12. In LMICs, it is 15 to 30%. The total number of blood cultures taken per 1,000 patient days. Expected is 100 to 180. So there should be a higher index of clinical suspicion in neonates who present with signs and symptoms of sepsis. There should be no missed opportunities, which means that in all cases where you start antibiotics, you should take a blood culture. Volume should be at least 1 ml. The needle to incubator time should be less than 4 hours. This we discussed. This helps us. Such quality indicators for blood culture will guide us with the antimicrobial use and also decrease the antimicrobial resistance. What is the role of sepsis screening then? Because I have stressed so much on blood culture. So sepsis screen is a combination of various investigations. It includes total count, absolute neutrophil count, IT ratio, micro-SR and CRP. When 2 or more parameters are positive, we take it as a positive screen. If it is abnormal, it has to be repeated. What is more important about this is positive predictive value is very low, 27% only. What does it mean? When you have a positive sepsis screen, the possibility of having true sepsis is very, very low. However, negative predictive value is very high, which indicates that if your sepsis screen is negative, the probability of sepsis is very low. So you can use sepsis screen to rule out sepsis rather than to diagnose sepsis. And please remember that individual components do not have much significance compared to a composite score. However, when the baby is symptomatic, do not waste time in doing sepsis screen. Start antibiotics after you take appropriate blood culture in symptomatic babies. CRP and often procalcitonin is used in the diagnosis of neonatal sepsis. CRP, bedside point of care, qualitative CRP comes out very cheaper. Quantitative CRP is also available. Compared to CRP, procalcitonin is a little bit more accurate. However, the cost of test is much higher compared to CRP. So, we should remember that CRP and procalcitonin is not only influenced by neonatal sepsis, but they can be elevated with maternal fever, meconium stain like fetal distress, as well as the age of the baby. So, relying too much reliance on sepsis screen is poor because positive predictive value is poor. However, in mildly symptomatic babies, 2 sepsis screen, serial sepsis screen, or 2 serial CRPs if they are negative, we can rule out sepsis. We can withhold antibiotics and observe the baby rather than be driven by a positive CRP. So, this is the guideline from the NNF, which suggests that do not use CRP routinely for diagnosis of suspected late onset sepsis. However, in SNCUs, where you do not have blood culture routinely, you can use it as a screening tool, again to rule out sepsis. So, if your CRP is negative, you can withhold antibiotics rather than using CRP to diagnose sepsis. And they also say that there is no advantage in using procalcitonin over CRP as a screening test for late onset sepsis. Finally, I will discuss on antibiotic stewardship, which in simple terms means using the right antibiotic for the right infant for at the right duration and in the right dose. So to use antibiotics, we should know the unit's antibiogram. This is how we can create an antibiogram for each culture that you get plotted on the respective antibiotic. Excuse me. To derive the unit antibiogram. But when antibiogram is not available, this is a simple recommendation that can be used, which can guide us. So when sepsis resistance strains are less common, we can use penicillin with an aminoglycoside combination. However, where resistant strains are more likely, as in nosocomial setup referral units, you can choose piperacillin tazobactam with aminoglycoside. If MRSA is suspected, then only vancomycin should be used. NNF guidelines also suggest that to have a local policy. However, they suggest against using third generation cephalosporin or higher spectrum antibiotics as a first line empirical use, especially in special care neonatal units. In these areas where resistant bugs are less likely, it may be preferable to use the WHO recommended first line antibiotics, ampicillin and gentamicin, and be guided by the blood culture results. Again, duration of antimicrobials are very important. These are ICMR recommendations. For pneumonia, 5 to 7 days. When we have blood culture positive, 10 to 14 days. Meningitis, 21 days. Most of the burden comes when you have a clinical diagnosis of sepsis with sterile blood culture and normal CSF. They recommend that you can restrict the antimicrobial to 5 to 7 days if the baby improves and the only CRP had been positive. So a shorter duration of antibiotics for culture negative sepsis with good clinical improvement. This forms the chunk of the cases. So in summary, please assess for maternal risk factors in early onset sepsis. The calculators used in high income setting is not applicable to our setup. Assess the babies for clinical risk factors. Remember the red and yellow flag sign. We can use a sepsis screen not to diagnose sepsis, but to rule out sepsis. They have a very high negative predictive value. There is no advantage in using procalcitonin over CRP. Finally, the blood culture is the most important investigation for diagnosis and management of neonatal sepsis. All units should have the culture of sending blood cultures, trusting the blood culture report, and making every effort to make sure that contaminant rates are lower. These help us to improve the quality of blood culture and to reduce antimicrobial resistance. So with this, I end my presentation and thank you so much for giving me this opportunity on the National Newborn Week to share my thoughts. Thank you, ma'am.
Thank you so much, ma'am, for excellent presentation. Dr. Kunal?
Thank you so much, ma'am, for it was a wonderful presentation. And I would like to thank, as there are no questions, if anybody has any questions, they can ask. You can unmute yourself also, or you can put in the chat box also.
I have a question.
Yes, sir.
Not really, I don't know whether it's a good question, but a lot of antibiotic resistance comes from veterinary usage of antibiotic in animal feed or chicken feed or whatever. So how is it that we can, because I think you quoted studies and we know that even when patients come directly to us from the community without receiving antibiotics, they already culture quite a few antibiotic resistant organisms. That is one. Second, there are, I think, reports from metros, and I'm sure it is there in other places, but since research is not there, we do not know. Groundwater is contaminated with fecal matter, because there is no good drainage. So, and there are these cholera outbreaks which happen on and off in various cities, which is an indication that fecal matter contaminates the groundwater, and much of the supply in most of the cities is actually groundwater. Everyone does not get running water from rivers. It is beyond the scope, but I thought these are two things which affect the newborns, but I don't know what we can do to solve it. How can we do? So,
Yes, sir. Points are well taken. We focus on babies. Whatever happens in the community is beyond our control. So we should, general awareness is very important.
So, ma'am, there is one question from the delegates that if patient is already on the antibiotic from outside, how much is the blood culture useful? Also, of septic screening negative baby stable, can we stop?
Yes, if
What's your thought on that one?
And the baby's symptoms are improving and the risk factors are less, then we can stop antibiotics, keep the baby under observation. If they are already on antibiotics, better to reassess at 48 hours whether antibiotics need to be de-escalated. Ideally, general awareness of starting, taking blood cultures before starting antibiotics is very important.
Should we send a new blood culture, ma'am? The question
If you
is.
think that there is a worsening, baby is already on antibiotics and there are new symptoms, or you think that the baby is not improving, definitely a blood culture needs to be sent.
And also CSF MRI, ma'am. Do you think we should take the lumbar puncture?
Lumbar puncture for in the early onset sepsis cases, risk of meningitis is less. So in asymptomatic babies who are being screened only for maternal risk factors, it is not needed. However, even in early onset sepsis cases, if there are clinical signs and symptoms, CNS signs and symptoms, then a blood culture should be taken. Definitely, if the blood culture comes positive, then a lumbar puncture needs to be done. So these are two indications in early onset sepsis where lumbar puncture should be done. All cases for evaluation of late onset sepsis should have meningitis rolling.
So there are no more questions. So thank you so much, Sindhu ma'am, the presentation. I would like to thank AOP Gujarat, Tushar sir, for sparing his time. Thank you so much, Vadodara Snehal ma'am, for sparing our time and being there. Also thankful to Dr. Somsekhar sir. Our EB members also are there. Dr. Urvi is there. Thank you so much. Thank you, Vishal, for excellently moderating the session. So, and thank you so much for all the delegates who for being there. So I think we can now conclude the session.
thank you very much.
Thank you.
Very nice.
Thank you so much, ma'am. Thank you.
Thank you very much.
Thank you. Bye.
Thank you.
Bye.
Thank you.
Bye. Rupsa, we can end the session now. Rupsa, are you there?
Yes, sir.
And wind up this.
So thank you so much, everyone. Am I audible, sir?
Yes, you are audible now. Yes, Rupsa, you are audible.
Okay, sir. So, sir, can we conclude the session?
Yes, yes.
Okay, so thank you so much, everyone, for extending us the opportunity to host this session. So with this, we would like to conclude today's session over here and looking forward to host you again. Thank you so much, everyone. Have a good day.
Thank you so much, Rupsa, and thank you to ClearNet for the seamless experience.
Thank you, sir. Thank you so much, sir.